Okay, I think we can get started. So again, welcome to today's webinar. I am Allison Northrup. I'm the Associate Director for Public Policy and Government Affairs at AMCHIP, the Association of Maternal and Child Health Programs. Today, I'm pleased to be representing the Maternal Health Learning and Innovation Center, or MHLIC. We are grateful to be partnering with Postpartum Support International's Mind the Gap Coalition and the Center for Law and Social Policy, or CLASP, for this webinar. We, our presenters, and together as audience members, will be exploring systems and policy level changes to promote perinatal mental health quality outcomes, particularly for people of color. Next slide, please. MHLIC, again, the Maternal Health Learning and Innovation Center. We are a collaborative of organizations dedicated to maternal health and maternal health outcomes. We connect maternal health learners with maternal health doers and develop, catalog, and share best practices related to maternal health improvement. These are the partners, the core partners of MHLIC on your slide right now. We have a national training and resource center that can be found at maternalhealthlearning.org. I can tell you it is a beautiful website. Please do check it out. MHLIC is grateful for funding and partnership with the Health Resources and Services Administration, or HRSA. Next slide. And we want to thank PSI, Mind the Gap, and the Center for Law and Social Policy for putting together the content for today's webinar. I'd like to take this opportunity to introduce you to our panelists today. Isha Weerasinghe with the Center for Law and Social Policy, Jennifer McKeever with the Riley Group, and Jen Davis with Postpartum Support International. There is or will be soon a link in the chat for those who would like to learn more about the presenters and their work. Next slide, please. Just a few reminders and helpful tips. So we will be and have already begun recording today's webinar. We will share the recording via email with all registrants. And we'll also add it to the MHLIC Resource Center at maternalhealthlearning.org. All participants are muted, but that does not mean we don't want to hear from you. We'll have time for Q&A at the end of the presentation. So please use the Zoom Q&A box or the chat box to enter questions throughout, and we'll get to them at the end. If you use the chat, please be aware that you have the option to send your questions or comments to all attendees or just to panelists. You can select which audience. We also have a short evaluation survey for participants that you will see links to at the end of the webinar. Next slide. Again, please be sure to connect with the Maternal Health Learning and Innovation Center on social media. Check out the website. We would love to work with you and get to know you better. And now I will turn things over to my friend, Jennifer McKeever.
Hi, thank you, Allison. I am happy to turn things over to my friend, Jen Davis.
Thank you so much. And hi, everyone. So excited to be here with you all today. Again, I'm Jen Davis, and I am the chapters manager at Postpartum Support International. So I will start off just walking us through what we're going to cover during today's session. You can advance to the next slide. So we're going to start just grounding ourselves in perinatal mental health and the why around this work, and then move to talking about the Mind the Gap initiative, really to ensure that perinatal mental health continues to be and is the national priority, advancing equity in maternal mental health. And then we'll close out around building a national advocacy network and how you all can get involved as we push this work forward. Next slide. So I know, and I am assuming that there is a lot of rich expertise in this room, and many of you are experts in perinatal mental health, but just want to take a moment to ground us in a common definition. So when we're talking about perinatal mental health, especially in today's session, we're really referring to a woman's mental health during pregnancy, as well as the first 12 months after delivery. And when we're thinking about perinatal mental health disorders, that includes depression, but that's not the only disorder that we're referencing when we think about perinatal mental health. So just want to notate a few things. First, perinatal mental health is not just postpartum, right? It can occur during pregnancy. It can be that baby blues period within the first few days up to 2 weeks after birth. It can really happen again during pregnancy and beyond. So sometimes when we think about postpartum, we assume that it all is occurring after the birth, and that's not the case. Next, perinatal mental health is not just depression. It includes obviously depression, but anxiety, OCD, PTSD, bipolar disorder, and then less frequently, but still obviously current, is postpartum psychosis. So all of those, when we're thinking about perinatal mental health, all of those are included when we're referencing that. Next, perinatal mental health is not just around moms. It's not just about moms' hormones. Fathers and same-sex partners and adoptive parents, grandparents, all of them can experience a level of perinatal mental health. And then finally, when we're thinking about treatments, there are so many options for treatments, whether it's support groups or therapy, medication, as well as additional specialized supports. If you're thinking about breastfeeding or sleeping patterns or just daily tasks, all of that is included when we're thinking about treatment options for perinatal mental health. And I just want to highlight a quote from Nancy Byatt. Mood and anxiety disorders are the most common complication of pregnancy. Maternal suicide is a leading cause of pregnancy-related deaths, and more postpartum women die from suicide from any other medical cause. And this is why that this work is everyone's business and why it has to continue to be a national priority. You can move to the next slide. So just doing a bit more framing around the why of this work to understand the impact that perinatal mental health can have in the US and across the world. So there was a recent study from Mathematica that really dives into this. And I'm sure some of these data points are very familiar to many of you, but we'll just highlight them quickly. So 1 in 7 pregnant and postpartum women are affected by PMAD, so perinatal mood and anxiety disorders. They're actually the number one cause. I'm so sorry. Okay, so they're actually the number one complication of pregnancy and childbirth. And half of the women diagnosed with depression, they don't get treated, and less than 15% of women with perinatal mental health disorders are treated. So there is a clear economic burden of PMADs when they're left untreated. Actually, it's about $14.2 billion for all births when we're looking at births that happened in 2017. So if you break down the costs, 60% of those costs are attributed to poor maternal outcomes, while 40% are attributed to child outcomes. And that amounts to about $32,000 in societal costs per mom with PMADs and her child over a 6-year time frame. So when we're thinking about undiagnosed and untreated perinatal mental health disorders, it's really a silent crisis here. And these conditions have such a significant impact on maternal morbidity and mortality, as well as infant and child health, and family health, community health. It does not impact only mom. We're talking about the whole community and family system that is impacted by PMADs. So when we're talking about this is a crisis that is not impacting only our moms, but it can have an impact on everyone. You can move to the next slide. So if you're on this call, then I'm pretty sure that you know that maternal mortality is a crisis in this country. At 17.4 deaths per 100,000 live births, our nation suffers from a higher rate of maternal mortality than any other developed country. Our rate of maternal death is more than twice as high as other nations with comparable wealth. So the moms in today's nation are more likely to die than their mothers were when giving birth. So let's just pause on that for a second. Mothers today are more likely to die in childbirth than their mothers were. And what is even more disturbing is that according to the CDC, 60% of these births are untreatable. And 60% of these deaths, are untreatable. So 60% of the deaths that are happening right now could have been avoided if there were the right systems in place. And also what is more unconscionable is the crisis that is harming Black women. It's at alarming rates. We are more than 3 times more likely to have maternal death than white women. And when we think about the reasons that this is happening, it can be because of lack of social support. It can be lack of food security, lack of access to services, lack of insurance or information, which really places an unfair burden on the individual, while missing out the call that there are racist systems and structures that are in place that are really creating these lacks. But we are seeing strides in the right direction with the Black Maternal Health Caucus in Congress, the large provisions for Black maternal health omnibus, hearings on Black maternal health. We are seeing strides in the right direction, but there's still a lot of work to be done. You can move to the next slide. So as with all maternal health issues, Black women, again, in the US are at a higher risk for perinatal mood and anxiety disorders. They're less likely to get treated. They're less likely to receive quality mental health care. 1 in 3 African-American mothers suffer from depression compared to 1 in 7 when we're talking about white moms in the US. And women of color often suffer in silence. And I can speak about this firsthand. I have 2 children. I have an almost 9-year-old daughter. I have a 2-year-old son. And with both of my pregnancies, I suffered from depression and anxiety. And I never talked to anyone about it, including my husband, who had just found out that I was going through this when I started working with Postpartum Support International. I just felt like it was something that I was just supposed to handle and I was just supposed to deal with. And there were not a lot of conversations in my family community or my community about depression or anxiety or how to address it. So I ended up doing research on my own to learn more. But again, this can be a silent crisis because we either don't know where to go or there just are not a lot of conversations that are happening around this being a real issue. So you just feel like you're just supposed to figure it out and deal with it yourself. So it's definitely considered, especially in the Black community, a silent crisis that is taking place. Next slide. But when we think about the impact of it unaddressed and untreated, again, it has a societal impact. It has an impact on mothers. It has an impact on children, but it also has an impact on fathers in the community. But when we think about the societal impacts, we're talking about increased use of public sector services, income loss and reduced economic outcomes, increased healthcare costs. When we think about moms specifically, higher work absenteeism and low labor force participation, an increased likelihood of suicide, and an increased risk of maternal health overall. And then for children, there's an increased risk of low birth weight or preterm birth, increased risk of behavioral and developmental disorders, increased risks of SIDS. So there are a lot of impacts that can be seen across the society when these issues are going on unaddressed and untreated. So I'm going to turn it over to Jennifer to talk a little bit more about the Mind the Gap initiative and how we're pushing to make sure that this is a priority across the nation.
Great, thanks. Thanks so much, Jen, and thanks for laying out again the why for us, the why it's so important that we include perinatal mental health in all efforts to improve maternal health. If we leave you with one thing today, I hope it is this, that any efforts to improve maternal health are incomplete without a focus on maternal mental health and perinatal mental health. So I'm pleased to handle the portion of the webinar where we're talking about the what. So what are some of the things that we are doing about this perinatal mental health crisis? And specifically, I'm going to talk to you about a national initiative called Mind the Gap that is working at national and state levels to turn the tide on the perinatal mental health crisis. Slide. First, starting on the right-hand side of the slide, Mind the Gap is a national initiative that is led by Postpartum Support International, implemented in partnership with a coalition of organizations with the shared aim of ensuring that perinatal mental health is a national and state priority. We do this work by advocating for and advancing policy and legislation that will improve outcomes. So the framework for our efforts can be seen on the left-hand side of the slide, where we are viewing that to improve outcomes for perinatal mental health, there are several key factors that we need to focus on. You can see the pillars show what these factors are. Education, screening and follow-up, and access to treatment and services are critical to improving perinatal mental health outcomes. So when we talk about education, it's both public awareness as well as professional and allied healthcare education about maternal mental health disorders and where to find help, where to refer your clients if you are a provider. Screening should be routine and standard during pregnancy and the postpartum period. And the screening needs to include referral and diagnosis, which then leads to treatment. And women and families then need unfettered access to treatment and services, which means coverage in public and private insurance to an array of medication and support services in the clinic and in the community. Slide. So Mind the Gap works at the nexus of mental health, maternal health, women's health, infant and child health by engaging over 40 organizations to advance policy and legislation. You'll likely recognize some of these organizations, many of which have both a national presence and a state level presence, like, for example, Postpartum Support International, the March of Dimes, and Mental Health America. I'd like to ask you if you wouldn't mind writing in the chat right now, do you know if you have a state chapter of one of these organizations, either Postpartum Support International, Mind the Gap, Mental Health of America? Are you aware of these organizations in your state? And do you have a relationship or a connection with that chapter? So Mind the Gap convenes the coalition once per month to review our shared priorities and identify opportunities to amplify each other's efforts. So oftentimes this will be in the form of signing on to an advocacy letter or disseminating for others to sign on, providing updates about specific legislation as it passes through the halls of Congress, and mobilizing at critical points in the legislative process. I am happy to see, as I was talking, the chat feed scrolling by and lots of yeses on connections with your local chapters. I encourage you, if you don't have that connection already, to go ahead and reach out and make that connection so that you know that there are mental health services available to any of the birthing individuals that you're working with. So we focus on policy and legislation. I'm going to talk a little bit about why. If you could go to the next slide, thank you. So it's really quite simple why we focus on policy and legislation, and that's because it can change lives. So I would like to use Medicaid as an example. And I'm wondering if, while I do that, you can tell me in the chat if you are in a state that has expanded Medicaid, yes or no, or do you know how long your Medicaid postpartum coverage lasts. So if a woman or person is pregnant, has a child, how long will their Medicaid last? Is it 60 days, 6 months, 1 year? Let us know about that as I'm going through this slide here. So using Medicaid as an example, in March, the Medicaid Action and CHIP Payment and Access Commission, the MACPAC, which is a commission that was established to review and provide recommendations to Congress about Medicaid and child health insurance programs, provided a recommendation in its most recent report, which was March of 2021, that recommended lawmakers consider that Medicaid cover birthing persons for 1 year postpartum. They also recommended that the federal government cover that at 100%. So that was a pretty significant recommendation that came out of this advisory commission that advises Congress on Medicaid. We also saw around this time, legislation had recently passed, the American Rescue Plan Act, which gave states an option to extend Medicaid from 60 days to 1 year. So that's not a federal requirement. It is an option for states, and there are some incentives in taking that option. And it kicked off a domino effect of many states proposing in their most recent legislative sessions to extend Medicaid coverage from 60 days to 1 year. So several bills and legislation were proposed for extending the coverage, and in many states that did pass, so that 1 year of coverage is now in law. In some states, unfortunately, it did not pass, and in other states there was, somewhat of a compromise, if you will, in extending coverage to 6 months. And then also in the meantime, we are continuing to see research and data that's being released about the maternal health and the mental health crisis. And there are some initial studies that are showing us actually that states that expanded Medicaid saw improvements in maternal health outcomes. And so that is information that we can use to educate our policymakers and legislators about the importance of continued Medicaid coverage. And then advocacy. We support all of this through advocacy by picking up the phone and making phone calls, sending letters, holding meetings with lawmakers, kind of beating the drum to support and pass this legislation, both at the national and the state levels. Next slide, please. So here is some of the federal legislation that we are supporting. The first is around Medicaid. So I just talked about that a little bit. But there is actually a current proposal to make it mandatory for states to provide Medicaid coverage 1 year postpartum. So it's not an optional offering. It is mandatory for all states to provide. We also have been watching the Black Maternal Health Omnibus, which includes 12 bills aimed at improving Black maternal health. 8 bills of those include mental health provisions, which we're excited about. Many of them touch on the need for accurate data to understand what is the true impact of mental health on maternal health and maternal mortality. A lot of times in the morbidity and mortality review committees, causes of death from mental health complications are not documented as well as they could be. So there are some efforts to improve that data collection. And then also many of these are focusing on workforce, and that is both expanding the workforce and building the capacity of the workforce, and also include diversification of the workforce and who is actually serving women and persons who are pregnant and delivering. We're seeing a lot of this play out right now. If you look over to the right in the Build Back Better Act, And, you've probably seen a little or a lot about this. It's the 3.5 trillion is the number that they're throwing around. And the current version of the Build Back Better Act includes this provision to extend Medicaid for 1 year postpartum. And many of the provisions, actually, I think all of the provisions from the Black Maternal Health Omnibus in it right now. So it has passed the House, but it is now in consideration at the Senate. And of course, there is debate about, how much money will be allocated for all of these provisions and whether or not it should be cut back, et cetera. And so we're doing a lot of work right now to really advocate for all of these investments to be included in the Build Back Better Act. It's a little bit tricky to say. We also have our eye on a few federal programs. One is called the Maternal Depression and Related Behavioral Disorders Program. It was created a few years ago and aimed at improving the mental health and well-being of pregnant and postpartum women, and in turn supporting their emotional health and the emotional health of their families. It also aims to increase healthcare providers' early identification of maternal mental health conditions and uses evidence-based and culturally appropriate practices to provide women treatment and referral. So when that program was announced several years ago, over 30 states applied for that funding. It was a total pot of $5 million, which isn't a lot, but over 30 states applied for that money, and then only 7 were actually funded. And so I would love to see in the chat whether you know if your state applied for this funding or is actually one of the 7 states funded. And I can tell you in a minute who those states are. But the good news is right now there is a federal allocation to expand from $5 million to $10 million. We still think that's a far cry from what it should be, but it's doubling, so it's at least going in the right direction. And so we've got our eyes on that to see whether or not, how that additional $5 million will roll out, whether there will be an opportunity for additional states to apply for it. So that's something that we've got our eye on, and you might want to put your eye on that too. So the states, I see, thanks for your answers in the chat. The current states that are funded under this program are Florida, Kansas, Louisiana, Montana, North Carolina. I saw somebody say, I'm not sure about North Carolina. North Carolina, Rhode Island, and Vermont. Another federal program that we're watching is the Maternal Mental Health Hotline. So just a few short days ago, this did not exist, and it now exists. HRSA is going to be releasing in early 2022 a maternal mental health hotline that Jen will talk about momentarily. It is something that Postpartum Support International is going to be implementing for HRSA, so we're really excited to see that service be available to families and birthing persons. And then lastly, I just want to mention that we also have our eye on telehealth, which is kind of incorporated in all of these other bills, because during this public health emergency with COVID, it's become very apparent that telehealth has been very beneficial for people struggling with mental health issues because it provided easier access to treatment and support. So the Mind the Gap effort focuses on these issues on a national level, and then we also have a state policy series. So the purpose of the state policy series is to focus on improving access and coverage for birthing individuals, and we do that by implementing a series of 3 meetings where we bring together multiple stakeholders to identify an issue, a priority, to determine a plan to address that priority, and then to tackle that issue. And so I said I have worked in public health, and I know that we are big fans of planning, and we can do lots and lots of planning. And by the time we get to implementation, our plan might be outdated. And so this series is really about how do we get to action as quickly as possible to advance a particular policy or legislative issue in our state. The image you see there is the state capital of Texas, because we actually just wrapped up earlier this week with the series in Texas. And it was implemented or in partnership with Texans Care for Children, the Postpartum Support International Texas chapter, and a St. David's Foundation, which is a local, actually Austin-based, Travis County-based foundation. And so what we worked on with them is they had an unexpected win in that their legislation did approve a 6-month extension of Medicaid postpartum. However, if you read the fine lines of that, there is a lot of work that has to be done to actually implement that piece of legislation and make it a reality. One of the snafus in there is that auto enrollment from Medicaid. So once coverage ends, a woman would be transferred to a program called Healthy Texas Women Plus. It's sort of a supplemental insurance program. And some administrative trigger required the ending of that auto enrollment process. So with a public health emergency likely going to end at some point soon, we anticipated that a lot of women are going to be falling off Medicaid without the supplemental insurance program to help provide that support. So we worked with them to, convene a group of close to 100 stakeholders. And sorry if you just heard that, I think a picture just fell off my wall. But close to 100 stakeholders to really tackle this issue, and they've got now kind of like an action plan set up. They've got meetings starting tomorrow with how they're going to address this auto enrollment concern. If that's something that you are interested in, considering a state policy series in your state, I hope you'll write that in the chat. Just add your name and let us know that you're interested, and we'll be providing more information in 2022. I'm watching my time, and I'm a little bit short on time, so I'm going to probably make this my last slide. Thanks for transitioning for me. So the Mind the Gap strategic plan, the coalition of organizations came together with all of this data about the perinatal mental health crisis in 2019 and devised a strategic action plan to really turn the tide on this crisis. So I know there's a lot on this slide and you're not going to be able to see everything, but I do want to point out that there are 5 kind of priority areas for focus and action. That is awareness and help seeking, screening and follow-up, access and coverage, education and training, and clinical and prevention research. And so what we'd like to encourage you to do on this call is, I'll put a link in the chat in a moment for you to access this plan and download it. And I think it would be really helpful if you could look, whether you work in the nonprofit lane, the government lane, direct services lane, if you can think about your work and how your efforts are aligning with this Mind the Gap National Strategic Action Plan, I think then together we can make a difference. So I am going to turn it over to my colleague in just a minute. I hope that if we haven't yet, we soon will convince you that no maternal health effort is complete without a mental health focus. And so I've talked about one initiative that's working to advance national and state policy legislation. And I'm now going to pass it to my colleague, Isha, who is going to talk with us about centering racial equity in our maternal mental health efforts. So Isha, can I pass it to you, please?
Yeah, thanks, Jennifer. Hi, everybody. I'm Isha Singha. I'm a senior policy analyst at CLASS, which is the Center for Law and Social Policy. And yes, I'm going to be talking to you all today about centering racial equity in maternal mental health and some of the work that we've been doing. And I just wanted to give you a little bit of background about CLASP before I get started. So CLASP has been around over 50 years, and we started out as a legal services organization, and then over the years really became more of a policy and advocacy shop. And we're an anti-poverty organization, and I focus on mental health at CLASP. And the two areas that we really focus on are thinking about parental mental health and the mental health and well-being of youth and young adults. So just wanted to give you that context, and all of our work, and I would say particularly in some areas and particularly in mental health and well-being, centers racial equity. It's a core part of the work that we do. So next slide, please. So I'm going to be talking about a paper that I co-wrote with one of our mental health advisory board members, and I put the link to the paper in the chat that is really focused on value-based efforts. So how payers can think about being more inclusive of different birthing persons, not only thinking about different birthing persons of color, but also thinking about people with different gender identity, sexual orientation, and disability status, etc. But I think that this can be applied to work that you all, if you all are interested in pushing forward racial equity in your state, county, etc., I think it can be applied to that. So I just wanted to give you a picture of what the data tells us to add to what Jen was presenting in the beginning. So next slide, please. If you look at the recent set, well, recent, quote unquote, recent, from 2018 from the CDC PRAMS data, which is, I'm sure most of you know, the Pregnancy Risk Assessment Monitoring System. This is just an overview of the prevalence of self-reported postpartum depressive symptoms, and I pulled out race and ethnicity stats. So you'll see here the highest prevalence of self-reported postpartum depressive symptoms was among Indigenous people, and then followed by Asian and Pacific Islanders, followed by Black people, followed by the infuriating category of other, and then followed by Hispanic and then white people. So I will note that I said that the other category is infuriating because it just signifies that there are some limitations in how data is collected, and that there aren't enough race and ethnicity categories that people feel comfortable checking. And also for people who are biracial and multiracial, sometimes you may not feel comfortable checking just one category. And then another important limitation in this is that it's self-reported. So as Jen had mentioned at the top, there are a lot of people of color who don't want to disclose that they have depressive symptoms. So these numbers are most likely underreported and maybe not in the proportions that are actually is completely accurate, but we have to go with what we have. And then the other thing I wanted to note is that this was in 2018. So this was pre-pandemic, pre our country's racial reckoning, pre-anti-Asian hate, and also when thinking about job security, limited childcare, all of those factors are, of course, contributors to symptoms of postpartum depression and mental health. Next slide, please. So as I said, CLASP really looks at people living in low-income communities, so I wanted to include these stats as well. that studies, and there are several studies that show that women who are at lower socioeconomic levels are at greater risk to develop postpartum and or antenatal depression, and that women with lower incomes are less likely to report these symptoms of depression to healthcare professionals, even if they have access, even if they are able to access care through insurance, et cetera. So we really have to make sure that we're, of course, looking at coverage, which is incredibly important, but that we're also thinking about other factors like trust, the lack thereof, and what systems are in place to make sure that birthing persons feel supported. Next slide, please. So as I mentioned, there are some real limitations that exist across data when we're thinking about race and ethnicity, disability status, LGBTQIA plus identity, and primary language. And I just have an ask of you all, if you all do know of good models within your state or county or city of data collection, please feel free to put that in the chat, because I would like to learn more about them. And then limitations also exist when thinking about intersections between mental health and physical health. So example I'm providing here is focusing on depression and its relationship to cardiovascular disease. You could also think about depression and a relationship to oral health. Our system is so siloed that we're not really thinking about how if you come in for a physical ailment, that this could be really related to mental health, a mental health condition, or something or stress and anxiety. And then we really have this limitation in our systems about understanding the role that discrimination plays, whether in healthcare or outside of healthcare, and how that impacts the care that's provided and the care that's received overall. Next slide, please. So this, of course, leads to systems, these limitations. If we don't have the data that needs to show what limitations exist and what gaps exist and where the inequities exist, it's going to lead to systems that are ill-equipped to adequately and effectively meet the needs of all communities. So in this case, when we're talking about maternal mental health, it's going to lead to poor maternal mental health outcomes overall, and disproportionately so for people of color. And when I'm talking about people of color, I'm also talking about the intersectionality when thinking about different identities as well. Next slide, please. So I alluded to this framework that is in that paper, but again, I really think that it's important to think that you could use this framework not only if you're a payer or representing a payer, whether private or in Medicaid, but you can also, and in terms of thinking about how to make models more outcomes-based or value-based, but it could also be applied broadly to think about developing a racial equity plan in your state, in your county, in your city, or even thinking about within your practice, within the place that you're providing care. So the first thing is to look at data. So not only to think about data collection that exists. I mean, even if your practice doesn't collect data, you can think about public data sets and also data that exists among partners. So think beyond health, but including health, and think about social metrics and how data is collected, how data is used, and then think about what demographics are being identified. And then work to better understand who's enrolled in programs and who's left out. So that includes making sure that you're focusing on the infrastructure in the state and who is being provided care, going back to Jennifer's presentation and thinking about, for example, postpartum Medicaid and who actually has eligibility and who doesn't. But it's also thinking about within your work, having some serious staff reflections that focus on racial equity, center racial equity, and center the biases that many of us have. And then together with partners across sectors to develop and implement value-based initiatives that are centered around maternal health across race and ethnicity and other intersections, and then be able to incentivize them so that you are able to get equitable outcomes. So next slide, please. I'm going to break this down very quickly because I know we have limited time. So in terms of the first step is data collection. So again, I'm going to just reiterate that the data doesn't only have to be across health entities, but also thinking about social services and payers. And then it's important to identify the gaps that exist. So really think about who resides in your state and what data is not being collected. And then be open to add those fields to current data collection tables and make sure that there is a collection of data by different demographics. So some considerations that you could be thinking about is making sure that patients self-identify and also making sure that if you can't do that, making sure, and you are collecting data for birthing persons, that you're conducting culturally responsive data collection training so that you are not showing bias when you're asking the questions. Next slide, which brings me to step 2. So focusing on internal implicit bias. So it's important to be very open to assess and identify what programs exist that promote inequities and what programs exist that mitigate inequities and alter them as their need as needed. I would say step B is the most important step to make sure that you are including people enrolled in the program. So not only thinking about people with lived experience, but thinking about people who are interacting with the specific programs that you're focusing on to identify which health and social services need to be included in promising practices. So some states are really thinking about a maternity care bundle. So if there's a promising practice within your state, make sure to include somebody who is a part of that practice to let you know truthfully whether the practice is working or not. And then to make sure to examine racial biases in internal practices, procedures, and thought processes. And one way to do that, next slide, please, is to focus on education and internal bias training. So there are many internal bias trainings that exist. And if you all have examples of internal bias trainings that you have found to be very helpful, please drop them in the chat. But you want to make sure that these trainings include discussions about historical policies that drive inequities, because although we are talking about maternal mental health here, there's a slew of things that have happened in our history that have gotten us to this point that are driving these inequities. And as you all know, maternal mental health is connected to so many other different areas when we're thinking about the social determinants of health, when we are thinking about job security, childcare, your environment, your historical and cultural trauma, and the laws that have existed to increase inequities. And then also you want to make sure that implicit bias trainings talk about the myths upheld by the healthcare system. So an example is that Black people have a higher pain tolerance than white people. which unfortunately this myth still exists. If you look, for example, at New York Times 1619 project, there were reports of recent studies of physicians where a large number of physicians still believe that this myth still rang true. And this is why, one of the reasons why we are seeing higher maternal mortality rates among Black women. And then you want to make sure that you're developing community advisory boards, focus groups, and town halls to not only make sure that people are at the table, you want to make sure this isn't transactional, but that people are respected, that they're heard, and their time is valued and compensated for. Next slide, please. So one example of somewhere that has really great implicit bias trainings is the California Birth Equity Collaborative, which I'm sure many of you have heard of, but I have I put the link in here. Again, if you all have other examples, and I see some folks are putting them in the chat, thank you so much. If you have other examples, please drop them in the chat. Next slide, please. So after receiving the bias training, and again, I really think that this is something that everybody can do. We did this within our team with when we were providing technical assistance to states on maternal mental health. So you can look at the data and ask questions. And I'm not going to read all these questions, but just thinking about what types of providers serve pregnant and postpartum birthing persons in our state, and with thinking about workforce shortages, how can that be expanded, and how can birthing persons feel more supported? And then are collaborative care models used before, during, and after pregnancy? So collaborative care models meaning are your providers able to talk to one another while serving somebody who is a birthing person, and collaborating on your care and making sure that your care is being followed up on, etc. Next slide, please. And then you also need to ask bigger questions about increasing engagement among how do you reach more birthing persons of color, and how do you reach more LGBTQIA plus individuals? And next slide, please. So I'm going to go really quickly through this slide. So you need to make sure that you develop, the step 3 is to develop your model and process. So now you have a mechanism for stakeholder buy-in. Then together you're going to determine what needs to be done to understand the services that populations need. And then with that information, you can develop a health equity plan to address maternal mental health inequities. And if you're a payer, you can work on how to make a comprehensive maternal bundle care payment model, and also an implementation process. Next slide, please. So I mentioned this earlier, so I'm not going to go over this, but it's just really important that the framework includes an equity framework, of which there are many, and is really focusing on outcomes so you can incentivize providers to focus on outcomes and then penalize those who are really stalling progress. So I'll just stop there, and thank you so much.
Wonderful. Thank you all so much. I really appreciate everybody for joining and for sharing so much information. And I'm excited because it seems like there have been a lot of connections in the chat, which is fabulous. So I appreciate everybody sharing resources. We have about 5 minutes left, and we've had several questions come in and probably won't get to all of them. So I'm just going to go through as many as I can. I think if you have questions, please continue to send them in either through the Q&A and chat, and even even though we may not get to them today, what we will do is see if we can get some of those answered via email and send them out with the slides, recording and other resources. So the first question that came in chat was, can you all talk a little bit about how you have engaged Indigenous or tribal communities? The asker says that those communities are often overlooked and not engaged. So can anybody speak to that?
Sure, I can chime in a little bit, and I think I responded directly to that person, but through our PSI chapters, we're trying to make sure that we're more cognizant of it, making sure that that community is at the table as we're developing strategies and plans for moving forward and ensuring that perinatal mental health is a priority. So that's something that is definitely at the forefront for PSI as we're continue to make diversity, equity, and inclusion a priority across the board. So just leveraging our state chapters. And I definitely responded to that person to talk a little bit more to figure out where they're from and how we're intentionally doing that. But definitely determining how we can leverage our state chapters to ensure that all of our individuals are at the table, but especially our Indigenous populations. But not sure if anyone else has anything to add, but I just wanted to chime in because I responded to that person as well.
I'll just add quickly, when we were doing our technical assistance with states, it was also very important to us that Indigenous populations were included. So we had worked with our state partners to make sure that they were a part of the work. But I agree that they are often overlooked.
Wonderful. Thank you both so much. So another question has come in. Can you talk a little bit about how morbidity data is captured for persons whose pregnancies end more than 42 days before they present to care? Documentation of pregnancy relatedness of the mental health or substance use complication is often missed. Their state of Indiana is struggling to find ways to mine this information. Any ideas there?
Yeah, I guess our silence indicates no. We know that there are, I would love to go back and sort of read that question and digest it a little bit more and perhaps respond by email. It's a good one. And I think it's indicative of the bigger problem that our data is insufficient right now. And some of this federal legislation is targeted at improving that data and ensuring that we are capturing, mental health issues that impact mortality and morbidity. So sorry, I don't have a specific answer to that question now, but I'll read it again and see if we can follow up.
Wonderful. Thanks so much. I know it's something many folks may struggle with, and we can talk more about that and perhaps reconnecting. So we have about a minute left. So what I'm going to do is just put some our webinar evaluation in the chat, as well as some discussion questions that Jennifer and her team have put together that can help you as you're thinking about sharing this information or just reflecting on what you've learned and potentially next steps. So please go check those out. It looks like there's just so much connection and resources. So we'll be sure to pull in what we can from the chat when we send out follow-up. So I will just say to any of our presenters, do you all have any last thoughts or words you want to share with everyone?
Just thank you. There's a lot more information out there, so I hope we've piqued your interest to learn some more and get involved in perinatal mental health.
Wonderful. Thanks so much, everyone. Great. Thank you so much, everyone.
Everybody.